Okay, my slides are visible. Oh, thank you so much. So, good evening everyone, and I am Dr. Om J. Lakhani, and today I am going to talk to you about a very important topic, which is glycemic variability in type 2 diabetes. What is glycemic variability? Why is it important, and also what we can do to prevent it. Okay, so that is going to be my focus of my talk today. Secondly, in the same part of the system, we'll also discuss why DPP4 inhibitors are very useful in reducing glycemic variability. So this is what we are going to discuss in today's presentation. Okay, so let's start with the concept of glycemic variability per se. Okay, so let's start with the initial concept of glycemic variability. Now, some time back, they did an experiment where what they did was they wanted to see whether, they put some cells in two systems, okay, in two glucose solutions, right? So in one of the case, they kept the sugar high, okay, so sugar was persistently high. Let's say, blood sugar was, the sugar was in the range of 300, right? So, okay, let's say the sugar was persistently high. In the other system, what they did was they kept fluctuating the sugar, right? So sometimes the sugar was high, sometimes the sugar was low, okay? So what they found was, very interestingly, the case where the sugars kept fluctuating, the cell damage was more, okay? So there's more damage to the cells when the glucose were fluctuating compared to the situation where sugar was persistently normal. Now, this leads to a very important concept in clinical practice. Okay. Now, let's take three patients. Okay. So, let's say we have three patients, patient A, patient B, and patient C. Now, patient A has an HbA1c of 11%. Okay. Patient B has HbA1c of 8.5%, and patient C also has HbA1c of 8.5%. Okay. Now, let's see the risk of complications in all three, microvascular complications as well as macrovascular complications. Naturally, patient A, because of the high HbA1c, has the highest risk of complications in this three category. But what about patient B and C, right? Is there a difference in the risk of microvascular complication in patient B and C? The answer is yes. Now, the risk of complications here beyond HbA1c is determined by various factors. Now, it is determined by other risk factors. So, what are the factors which determine the risk of complications beyond HbA1c? So, it could be other risk factors. For example, the patient's hypertension, the patient's dyslipidemia, other things. It could be genetic factors. So, some people, even amongst diabetes, some people are more prone to develop, let's say, renal complications. Some people are more prone to develop, retinopathy, right? Some people are more prone to develop cardiovascular disease. So, there will be genetic risk factors. The third and the most important one, which is under our control, definitely, is glycemic variability. Right? So, glycemic variability is the most important parameter which we can control as far as diabetes is concerned with regards to this complication. Now, let's take the same patients B and C, patients B and patient C. Let's say the glycemic variability by whatever measure is X in patient B and it is 2X in patient C. Okay, so patient B, the blood sugar remains somewhere between, let's say, 160 to 220, right? It remains in this range, right? It is stable. But patient C, sometimes the blood sugar is 80, sometimes it is 70, and sometimes it is 300. So all in all, the average and the HbA1c remains same in both the patient. But in this patient, the blood sugars are often wildly fluctuating. And because of this wild fluctuation of blood sugar, patient C is more likely to have diabetes, micro as well as macrovascular complications. Now, why does this happen? So, the reason why this happens is that, remember, in the body tries to maintain a state of homeostasis. Right? So, body tries to maintain a system where things are in a stable state. Right? So, if your blood sugar is 300, though it is not good for the body, the body wants to keep it in a steady state. It doesn't want to change this state to something which is abnormal, right? So it tries to maintain the level of homeostasis. Now, what happens is when you have glycemic variability, the homeostasis is disturbed, okay? So let's say the blood sugar was 300, and for example, we use something called sliding scale, and that's why I very much dislike sliding scale. Sliding scale is actually very harmful to patients, right? So we describe, you have something called sliding scale. So what happens is, patient blood sugar is 300, you give insulin, right? Let's say you give 10 units of regular human insulin, blood sugar comes down to 220. Now somebody says, okay, give more insulin. So it comes down to, let's say, 70. Okay, so blood sugar goes down. Now blood sugar goes down, the patient eats, again it shoots up to 230. So again it goes up, right? Again, you wait for some time, it goes to 300, right? So you are doing this topsy-turvy. Now every time the blood sugar changes, you can see here, the blood sugar changes from 300 to 220, there is development of reactive oxygen species. Right? So there is increase of reactive oxygen species. Again, when the sugar goes up, right, again there is development of reactive oxygen species. This reactive oxygen species, they accumulate, and this accumulation of reactive oxygen species lead to damage. Right? So this damage often occurs because of this reactive oxygen species. So whenever the blood sugar goes down or the blood sugar goes up, there is a change in the reactive oxygen species, and this reactive oxygen species is what leads to both microvascular and macrovascular damage. So what can we do to prevent this microvascular complications, or to prevent this glycemic variability? So there are various strategies what we can do to do this, right? We'll discuss this in the rest of the presentation also, but a few things which you can do straight away is to use first of all, in terms of diet, what you can do is you can have a consistency in carbohydrate. Right, so you have diet which is consistent. Okay, so you can have a consistent carb diet, right? So carbohydrate meals, let's say every meal you are taking 30 grams of carbohydrate. This is one strategy of reducing glycemic variability. So every time you eat the same amount of food, same amount of carbohydrates, so again the glycemic response is similar. Second thing you can do is you can use drugs which can reduce glycemic variability. Now, which drugs can reduce glycemic variability? So if you divide the medications into two groups, right, one which reduce just a second. So one which reduce variability, second which increase variability or worsen variability. Now the increased variability, there are two drugs which are very popular in this group which can happen. One is sulfonylurea, other is premix insulin. These two groups, they increase glycemic variability. In sulfonylurea, because sulfonylurea can produce hypoglycemia, hypoglycemia leads to reactive defensive eating leading to high sugar. So sulfonylurea are notorious to produce increased glycemic variability, whereas you can reduce glycemic variability with various drugs like DPP4 inhibitors, with GLP-1, with SGLT2, with metformin to some extent, and basal insulin. So these agents can reduce glycemic variability. Now let us discuss how a DPP4 inhibitor reduces glycemic variability. Okay, so how DPP4 inhibitors reduce glycemic variability. Now DPP4 inhibitor, remember, DPP4 inhibitor inhibits an enzyme called DPP4. What does this enzyme do? So this enzyme breaks down two important hormones, GLP-1 and GIP. Okay, so by giving a DPP4 inhibitor, we increase the levels of GLP as well as GIP. Now what happens with this GLP and GIP? Okay, so when the blood sugar is high, let's say the glucose values are high, there is increased GLP-1 secretion, and this GLP-1 basically increases insulin secretion and it reduces glucagon secretion. Okay. So this is a, but when the blood sugar is low, GLP-1 basically does nothing. Right? It does nothing. Whereas GIP is very interesting. So GIP has a dual action. So when the glucose is, so GIP, when the glucose is high, it increases insulin, right? And it is neutral to glucagon. But when the sugar is low, it increases glucagon and hence prevents hypoglycemia. So when we are giving DPP-4 inhibitor, we are increasing the levels of GIP as well as GLP. So what happens is when the blood glucose goes high, right, there is increased GLP and GIP, both of which increase the insulin production. Whereas when the glucose is low, right, when the blood glucose is low, GLP would not do anything, but GIP would increase glucagon and hence correct the hypoglycemia. So this is the beauty of DPP-4 inhibitors, and that is the reason why DPP-4 inhibitors are very useful in preventing hypoglycemia as well as in preventing the glycemic variability. Okay, so by definition, glycemic variability refers to oscillation in blood glucose level, and it is usually defined by measurement of fluctuations of glucose, either related by parameters of glucose homeostasis over a period of time. So it could be glycemic variability, could be over days, right? So it could be something like, it could be daily fluctuations, it could be, monthly, or it could be long term, right? So you need to define a period of time in which you are looking at this glycemic fluctuations and variability. Okay. Now, so when we talked about glycemic management, and this is what we discussed earlier as well, when you're talking about glycemic management, you need to have a complete picture. You need to correct the fasting blood sugar, right? You need to correct the postprandial blood sugar. You also need to reduce glycemic variability. And then of course you need to reduce cardiovascular risk and other factors as well. So if you do all these things, you reduce the risk of diabetes related complications. If you do only one or two of these things, the problem is not solved. Okay. So if you talk about clinical scenarios, highlighting the HbA1c and glycemic variability, you can see I already discussed some patients like this. So you have patient 1, patient 2, patient 3, patient 4. Okay. Now patient 1 you can see is maintaining a very good glucose level, right? Patient 2 has HbA1c of 8%, but the blood sugar is fluctuating. Patient 3 again, patient 1 has, okay, so these are the glucose values, right? Patient 1 has high glucose, but it is stable. Patient 2 has high glucose, HbA1c is 8%, but it is variable. Patient 3 has normal glucose, but it is variable. And patient 4 has again normal glucose, which is steady. So of all these 4 groups, right, which patient has the lowest risk of complications? This patient. Okay. This patient has the lowest risk of complications, whereas this patient has the highest risk of complication. So patient, overall, if you see, the glycemic variability is very high in this, along with the high HbA1c. Okay, so that means that overall, and remember this patient is also going into hypoglycemia, patient 3. So patient 3 is also likely to develop a potential cardiovascular event as well. So what we need to understand is that not only do you need to look at the HbA1c, but you also need to look at the glycemic variability of the patient. Okay, so again, if you see the HbA1c itself, the HbA1c though is not a very static component, right? There are contribution of various glucose at various points of time in HbA1c cycle is different. So when the HbA1c levels start increasing, there is more contribution of the fasting glucose to the overall HbA1c, whereas when the glucose is lower, HbA1c is lower, there is more contribution of the postprandial sugar, right? So this is a very important concept that we need to understand when you are managing patients with diabetes. Okay, moving ahead. So remember the complications that happen, especially the microvascular complications, happen because of two reasons. I've already discussed this: sustained hyperglycemia and glycemic variability, right? So both these things are detrimental and impact the risk of diabetes related complications. So you have chronic sustained hyperglycemia with acute glycemic fluctuations, both of which lead to excessive glucose related end products and activation of reactive oxygen species, both of which ultimately lead to complications. Right? Okay. Now, why does what is the pathophysiological impact of excessive glycation and activation of oxidative stress? We all know that ultimately the complications really. So what I tend to kind of, if you want to bifurcate that, right, the increased advanced glycosylation end products mainly contribute to microvascular complications, whereas when you have the reactive oxygen species, they contribute both to micro as well as macrovascular complications. So if you want to really reduce macrovascular complications, you have to reduce reactive oxygen species. This is something which is important concept. So let's rule out the root cause of glycemic variability. Let's look at glycemic variability. We already looked at some of the parameters here. So what can lead to glycemic variability? So it could be fictitious, we'll see this. It could be because of lifestyle measures, it could be pharmacological, it could be biomedical. Let's look at each of these parameters. Now, what is fictitious? So fictitious is basically, sometimes it could be because of the glucometers, or it is the technique of blood sugar checking and all that. That is what can lead to the glycemic variability. And in such cases, basically, you can reduce the glycemic variability, understanding of it, by doing a CGM. Okay. Now, so especially, sometimes you have poorly stored glucometers or glucometer strips, or the patient does not have the proper technique of checking blood sugar. So all these cases can lead to fictitious glycemic variability. Then of course it could be because of lifestyle, right? So the patient does, it could be because of the variation in the food and composition of food and the timing of food. It could be because of, the exercise. Again, patient, let's say, sometimes what happens is that the patient, especially this happens in type 1 patients. So remember, when the patient exercises, so exercise has dual effect on blood glucose, right? So when you do a anaerobic or isotonic exercise or anaerobic, like for example, weight and all that, this leads to a transient increase of blood glucose. Whereas when you do a aerobic exercise, when you're doing like, running or walking or something, this gradually reduces blood glucose, right? So this is something you have to be aware about. Second thing what you have to be aware about is that no matter what exercise you do, after a few hours, right, the blood glucose goes down, right? So there is a delayed hypoglycemia which happens whenever you exercise. So a lot of the time, a patient is, now let's say you have a patient who is, exercising in the evening, right? And then after a few hours, the blood glucose goes down, right, in the night. So they develop nocturnal hypoglycemia, right? So exercise also can lead to hypoglycemia and glycemic fluctuations, right? So that is the thing. Patients can have abnormal sleep patterns, especially when you have obstructive sleep apnea, OSA. Obstructive sleep apnea is extremely important cause of glycemic variability. Of course, it could be psychological stress, physical and social environment, all these things can also, and again, patients' compliance in terms of the medications also can lead to all these problems. Okay. What about pharmacological, right? So we already discussed a bit of it. Now, of course, in terms of insulin, right, when you use a basal insulin or a basal bolus, the glycemic variability is less. Premix insulin, the glycemic variability is more, right? If you're using a regular insulin versus analog insulin, the glycemic variability is less. Again, in terms of preparation, sulfonylureas increase risk of glycemic variability, especially the traditional SUs. Amongst basal insulin, the ultra long acting basal insulin tends to produce less glycemic variability. Again, you have immediate release versus modified release formulation. So immediate release formulation produces more glycemic variability. Again, in terms of drug delivery, and it is very important, I say this very often, that a lot of the patients have lipodystrophy and other things, right? And the technique of injection, other things are abnormal, and that can of course lead to glycemic variability, right? So I think it's very important whenever you are dealing with a patient that you understand that you need to have a proper technique for insulin injection. Then of course pharmacological variabilities, we already said. So what you need to do is you need to use drugs. We already discussed what drugs are good in terms of glycemic variability, in terms of which increase or reduce glycemic variability. Okay, then you of course have biomedical cause of variability. What could be the other reasons? So it could be because of GI causes. So for example, patient has diabetic gastroparesis, malabsorption, diarrhea. It could be because of neuroendocrine causes, right? For example, hypoglycemic unawareness. It could be because of uh, pancreatic glucagon deficiency, right? Especially when you have pancreatic diabetes, right? Especially, so you have type 3C diabetes, right? So type 3C diabetes is known as type 3C is known as pancreatic diabetes. Okay. Now, in this case condition, what happens is that patient has damage to both insulin producing cells, alpha, beta cells, as well as glucagon producing cells, that is alpha cells. So they have both these things which are damaged. So you have neuroendocrine causes, right? Pancreatic causes. It could be, there could be associated counter-regulatory hormone issues, like for example, patient could have thyroid dysfunction, Cushing syndrome, cyclical Cushing's, pheochromocytoma, and it could be because of drug kinetics. There could be drug-drug interactions, and of course, metabolism of the drugs. For example, patient with chronic kidney disease, certain drugs will not be excreted in the way it is supposed to be. So these can all contribute to glycemic variability in patients. Okay. Right. Now, how do you evaluate the glycemic variability, and how do you evaluate in terms of the time frames? Now, as we discussed, the glycemic variability could be short term, intermediate term, and long term, right? So, when you talk about short term glycemic variability, we are talking about days, right? Within a few days, up to 3 days. If you're talking about intermediate glycemic variability, you're talking about 3 days to 1 month, and long term is basically several months. Now, all of these types of variability contribute to the complications that we discussed. Okay. So, how do you, assess for glycemic variability? Right, we'll come to this. Right, so how do you manage and how do you assess glycemic variability? Now, what is the impact of glycemic variability on various aspects of overall impact, right? So, first of all, it can impact cognitive function, right? So, especially recurrent hypoglycemia, or when the blood sugars are fluctuating, they can lead to cognitive information. Especially, you would have seen patients behaving abnormally when they are hypoglycemic. It could lead to hedonic tone and energetic arousal. So patient could be, there could be mood changes, right? The patient could be maniac or depressive, right? That kind of thing. And of course can correlate with depressive or anxious symptoms, and that can lead to cognitive dysfunction. So these are all, short-term impact of glycemic variability. Now, there's a study which looked at, glycemic variability on patients on insulin pump, and they found that reducing glycemic variability, short-term glycemic variability, improved the quality of life, which is, I think, anybody who suffers from type 1 understands this, that whenever you have high glycemic variability, the quality of life is definitely poor. Glycemic variability, remember, when you talk about variability, always remember that there is also more hypoglycemia. So remember, HbA1c is a poor predictor of hypoglycemia. So a better predictor of hypoglycemia is any accounts of glycemic variability, right? So if you can measure glycemic variability, we will see how we can do that. If you can do that, you are in a state where you are in a better position to estimate the risk of developing hypoglycemia. What about elderly patients? Remember, in older patients, high glycemic variability is particularly a problem because a lot of these patients actually have, they have, more hypoglycemic unawareness, and because they have more hypoglycemic unawareness, they can develop a lot of, severe complications of hypoglycemia, and also, of course, they will have cognitive impairment as well, so that can lead to contribute to the same. Okay. Overall, if you see glycemic variability, when you have hyperglycemia, we already discussed, there will be oxidative stress, epigenetic changes, inflammatory cytokines. Hypoglycemia can lead to platelet activation, can lead to inflammatory cytokines, can also lead to cardiac changes as well, and both of all this can lead to endothelial dysfunction, and that contributes to the diabetic micro as well as macrovascular complications, right? So all the complications that you see with diabetes, you can see here, a lot of them are contributed by glycemic variability, definitely beyond HbA1c. Okay, so when what is the impact of glycemic variability evaluation? So the patient continues to understand that there are patients where periods when the sugars are high and low, right? And the only drawback is that when you are trying to do this, you are increasing the patient's burden in terms of cost because you are checking more often. So it the negative aspect of checking for glycemic variability is increases the expenditure of the patient. Okay, so overall, in terms of summary, what is the impact of glycemic variability? It improves, it worsens cognitive impairment, especially when it's high. It worsens the quality of life of the patient, and on the other side, it improves the patient's awareness, and we can then prevent the complications. Okay, so how, which patient should be evaluated for glycemic variability? What kind of patients should you look for glycemic variability? Now, for example, if you have a patient with HbA1c of 7.1, and you are just given this patient a sitagliptin metformin combination, you don't need to check for glycemic variability. But if you have a patient with on multiple doses of insulin, or who has chronic kidney disease, elderly patient, all this type of patients, you need to look for glycemic variability. So typically any patient with insulin deficiency, for example, type 1 diabetes, pancreatic diabetes, etc. Patients who have poor caloric intake or who tend to have very high caloric intake, again you need to look for that. Patients with gastroparesis or erratic food absorption, patients who tend to miss insulin or compliance is an issue, irregular snacking of patients, patients who have issues in basal insulin administration, all these things you should look at glycemic variability for these patients, right? Now, so these are important patients, right, where you looked at glycemic variability in terms of that, right? How do you look for glycemic variability? Now, these are all various measures of various means of measuring glycemic variability. I think the simplest is to put I think in terms of practical sense, how do you measure glycemic variability? Put a continuous glucose monitor, CGM. Okay. So now all these modern CGM devices tend to have, right, CGM devices tend to have a concept called time in range, right, and the time in range is when the blood sugar is between 70 to 180 milligram per deciliter, and when you have blood glucose in this range, you should try to keep the blood glucose in 70% of your sugar within this range, right? So this is a very good, useful, simple measure of glycemic variability. There are of course more complex methods, right? So time in range is the simplest one. There are more complex ways. You can do a standard deviation and glycemic and coefficient of variation. You can measure this nowadays. A lot of these CGM devices give you the SD and CV, right? So you can look at these as well. Okay. How do you manage glycemic variability? So again, in terms of lifestyle, structured educational activity in terms of carbohydrate content of the food and other things, right? If the patient is diabetic and obese, you could use meal replacement. For example, you can use something like a diabetic meal replacement product, like your proteins with which replace. See, in such proteins basically reduce the glycemic burden and reduce variability. So these are various ways, right? You can see on the chart, right? You can use foods. I think one very good way, non-dietary, of course, which you can consider using is using acarbose. Right, so we discussed other things, but acarbose is a very useful drug also for reducing glycemic variability, right? So acarbose tends to slow down the glucose absorption, and by doing this, it reduces the glycemic variability, reduces both hypo as well as hyperglycemia. Okay. What about physical activity? So, one good way of physical activity, this is something which we always think. Remember, I told you that anaerobic exercise increases blood sugar and aerobic exercise reduces blood sugar. So, I think one good way of doing, is that you check the sugar, and the patient's blood sugar is, let's say, low right at the beginning. It's slightly on the lower side. Then you do an anaerobic exercise first, and then you do aerobic exercise. But if the patient's blood sugar is high, you start with aerobic, and then you go to anaerobic, right? So this is a good hint I can give you in terms of exercise, right? Okay. Then of course, these are the components of optimal glycemic control. We need to have reduce both glycemic variability as well as glycemic exposure. Glycemic exposure can be reduced by reducing the HbA1c, whereas glycemic variability can be reduced by better choice of therapy. Okay, right. So treatment decisions based on blood glucose excursion. One very important concept you need to understand is that when you are taking treatment decisions, especially, you need to have a planned treatment. It should be prospective rather than retrospective. So it should be proactive than reactive, right? So reactive control of diabetes is actually more harmful rather than proactive way. That's why sliding scale insulin is a bad idea, right? Because you are doing reactive, right? Sugar goes high, then you are correcting it. Instead of that, what you need to do is you have to prevent the sugar from going high or low. That's the how you should be taking your treatment decisions in terms of glycemic variability, right? What kind of anti-diabetic drugs should you consider? So you should use drugs which reduce glycemic variability. For example, you already discussed metformin, thiazolidinons. Again, newer drugs like Newer SUs, yes, but I generally feel SUs tend to produce more glycemic variability in general. So you can use incretin-based therapy, which are the best, right? And even SGLT2 inhibitors also reduce glycemic variability. If your patient is on insulin, perhaps giving basal plus therapy or basal bolus therapy is always better than giving, especially using newer types of analogs. And insulin pumps definitely reduce glycemic variability. So these are all ways in which you can reduce glycemic variability. Again, if you look at in terms of insulin, right? So if the patient is uncontrolled on oral hypoglycemic agent, you can start the patient with basal insulin, right? And this is again a completely separate chapter of discussion. We can discuss this in more detail. Right, now what is the role of gliptins in managing glycemic variability? We already discussed some parts of it, right, earlier. So basically, remember I told you that gliptins, they reduce both low sugar as well as high sugar, right? So that is one of the agents which is very useful in reducing glycemic variability, right? So there are many studies which have shown that use of gliptins reduces glycemic variability. This is a study by Pratley et al. Where they looked at using, so this is basically reduced glucose variability with glucose dependent versus glucose independent therapies despite similar glucose control and hypoglycemia rates in a randomized control trial in older patient with diabetes. So this is a randomized multicentral trial. They took two patients, right? In the first group, they used non-sulfonylurea oral hypoglycemic agents and a GLP-1 as the first injectable. And strategy B, they comprise basically non-glucose dependent therapies with sulfonylurea as the preferred OAD with glargine as the first injectable, and they looked at the endpoint in terms of the glucose parameters, right? So what they found was that in strategy, remember this strategy A, they used drugs which reduce glycemic variability. In strategy B, they use drugs which basically increase or maybe impact glycemic variability to a higher extent, right? So here they use things like insulin. Here they preferred using a GLP. Here thiazolidinone was common, right? Here they preferred using a glimepiride. Here they preferred not using it, right? They use DPP4 more here. Some of them was used here as well. So this is the difference in terms of the strategy, right? Now what you can see, right? Risks of hypoglycemia. So you can see how many patients in group A versus group B. So group B, remember, is the conventional strategy. Group A is where you use drugs which are having low glycemic variability, which reduce glycemic variability, right? In fact, what I would have done, I would have also added agarpos to this group here, right? Or you can use even SGLT2, right? So these are something which would help, right? So you can see clearly that the episodes of hypoglycemia overall are more in group B, right? Which is without a doubt, which is needless to understand, right? Again, percentage of time spent in euglycemia and hyperglycemia over a 24 period of time, you can see that now they're looking at something like a time in range, right? So looking at the time in range, greater than 70 or less than 180, more or less it is similar, right? But if you see again, at week 24, the time in range also changes a lot, right? So there are a lot of changes which happen, and nocturnal hypoglycemia is also definitely high with the situation where they have more of the drugs which tend to produce glycemic complication, right? Now again, if you see glycemic variability over 24-hour period, right, within the day, within 24 weeks baseline to, so different periods of time, again more or less glycemic variability is more with the strategy B, right? So the idea is that basically you can use drugs which reduce glycemic variability, and by using such drugs you are actually doing well in terms of the hypoglycemia risk. Now what I would have liked in this study, or to follow this study, follow up these patients and look at diabetes related microvascular complications and macrovascular complication. I'm sure the strategy 1, strategy group A, would definitely have lower risk of diabetes related complications because of multiple reasons. Remember, you are also using drugs like GLP which have cardiovascular benefit, but at the same time, right, overall in terms of reduction of glycemic variability would also contribute to lower risk of complications. Okay, now let's look at another study, which is a comparative study of use of DPP4 and SUs on glucose variability in type 2 diabetic patients on metformin. So this is a short study, 4-week randomized controlled trial. Now in this, each participant was prescribed metformin, randomly given either sitagliptin or 2 mg of glimepiride. What they were looking at glycemic variability using CGM. Okay, so very clearly you can see the MAGE was the criteria, that is mean amplitude of glycemic excursion. The MAGE value were definitely lower with the sitagliptin group compared to the sulfonylurea group, right? So basically what it tells us that within 4 weeks there is significant reduction of MAGE with sitagliptin compared to that of a sulfonylurea, right? So that is something which is very, very important to understand, right? Again, if you see the CGM patterns of these patients, you can clearly see here, right? This is at baseline and at 4 weeks later, right? So at baseline, they were okay, but at 4 weeks you can clearly see, right? There is some amount of difference. You can see here, right? Post meals, you can see quite a bit of difference, right? So this patient is, the patient on glimepiride definitely is still having excursions of glucose compared to the patients on sitagliptin. So when you give a metformin and DPP4 combination, we discussed earlier what are the pillars of diabetes management. So you need to control the fasting blood sugar, you need to reduce the post meal sugar, and you need to reduce glycemic variability. All the three should be done, right? So metformin, definitely we know it mainly targets the fasting blood sugar and it reduces the fasting blood sugar, glucose. DPP4 inhibitors mainly controls the post meal sugar. So again, post meal glucose excursions are very important. And again, we all know that DPP4 inhibitor and to extent metformin both reduce glycemic variability, especially when you are using that in combination, right? So that's something which is now very well known. So when you are using, especially in, remember, if you look at the chart earlier where I showed that when you have lower HbA1c, you have more contribution of post meal sugar. So hence, in such cases, the perfect drug would be a DPP4 with metformin combination, because what it will do is it will reduce all the parameters of the glycemic complications and the patient does very well on a long-term basis. Now, this is a study where they looked at effect of adding sitagliptin on reducing glycemic fluctuations in Japanese patients with diabetes receiving insulin therapy. Again, I'll tell you something very interesting. Sitagliptin is now approved for use in in-hospital management also. And what we have noticed, when we are using hospital hyperglycemia management for a long time, we have noticed that giving sitagliptin to patients on basal bolus insulin also, overall control is much better compared to those patients who are not given insulin, right? So that's something, not given sitagliptin. So this is something which is important. We have of course not published this study, but we have some data on this. So if you looked at this study, so what they did was the study included 13 patients with type 2 diabetes with stable glycemic control, but achieved either had been achieved after admission for glycemic control, and the insulin regime which included was long-acting basal insulin once daily in 4 patients and biphasic, premix insulin in couple of patients, right? Overall insulin dose was something between the range you can see here. Now they used the CGM and along with the insulin therapy on day 1 and 2, and patients were given sitagliptin as add-on therapy on day 3, 6 after the insulin doses were maintained. And what they wanted to see was the 24-hour glucose values, the MAGE and other parameters, right? So this is what what the idea here is, that does giving sitagliptin reduce risk of glycemic variability. Now very clearly you can see from this the 24-hour fluctuation. So one group, this is a group where the glargine alone is used, and the other group where glargine with sitagliptin. You can clearly see the glycemic variability over a period of time reduces with the use of sitagliptin. Similar thing was also seen with patient on premix insulin, right? So again, the glycemic fluctuation in terms of the actual number, you can see the MAGE value was 121 here, and patient on sitagliptin, which is 50 milligrams sitagliptin, the MAGE value was significantly reduced, right? So, overall, of course, the glycemic control is of course better adding a new drug, but and again in terms of hypoglycemia risk also, right? Overall, it was good, right? So that is something you need to, right? So again, to summarize from a glucocentric point of view, again you need to to overall summarize our today's presentation and the other things. Now, couple of things. I'll give you my own summary, right? Few things which I'd like to understand. First of all, right? First, an important summary that I would like to kind of point out is that we need to start looking beyond HbA1c. HbA1c is important, without a doubt, right? But you need to look beyond HbA1c, and a very important factor beyond HbA1c is glycemic variability. What is glycemic variability? It is fluctuation of blood sugar. How do you measure glycemic variability? Best way is to use CGM. And what you need to measure is time in range. Time in range is blood glucose between 70 to 180, right? And if 70% of blood glucose is between this range, you are doing well in terms of glycemic variability. Third important thing you have to understand is that glycemic variability has direct correlation with micro and macrovascular complications, and also glycemic variability impacts reactive oxygen species and has also impact on the advanced glycosylated end products. Okay? So these things are important, hence you need to keep this in mind. Important thing, drugs, which medications increase and which medications reduce glycemic variability. So medications which increase glycemic variability are sulfonylureas and premix insulin, whereas drugs which reduce glycemic variability are GLP-1 analogs, SGLT2, DPP4, carbos or AGIs, right, metformin, right, and basal insulin, especially longer acting ones. These are agents which reduce glycemic variability. Okay, so these are the important things in terms of the presentation, and I thank you for a patient listening.